Hi, welcome friends. Just let me know if you can see me live. So, welcome to another session of Medicoapps MCQ Live. I'm Dr. Abhishek, your mentor for these live sessions. And today is the ninth session, May 3rd at 5 p.m. So, these sessions have been inspired by a lot of feedback which I keep getting from my students that, sir, take MCQ sessions because whatever you teach in theory or whatever we learn in theory sessions, we tend to forget. But whatever you teach in terms of MCQ, we remember even in our examination. So based on that feedback, I have started this series of session every week, around 3 to 4 sessions I take. These are live sessions and purely MCQ, latest pattern MCQ with the concepts behind it. So in each session, I will be discussing 4 to 5 MCQs and brief concepts on those 4 to 5. So all these are very high topic, which are very important for your NEET PG examination, for your INI CET examination, for your FMG examination. All these questions are very important. So today is session 9. For anyone who is tuning in for the first time, I'm Dr. Abhishek. You are watching this live session on Medicoapps live channel. If you are new to this, make sure you give uh, subscribe to our channel so that whenever we go live, you can get notified. Once you subscribe, hit the bell icon so that you can get this notification. And even if you cannot watch these sessions live, you can see the recorded portion of this sessions. Give this video a thumbs up because it will help us to reach more and more students. If at the end of this session you have any questions or you have suggestions for future sessions, don't forget to leave your comments and share this session with your friends so that they can also join these sessions and we will have a large Medicoapps community who can participate in these sessions. Before I start, a small announcement. I personally have created a few WhatsApp groups where I send daily updates. Now, what are these updates which I send? I'll send this concept card. About concept card, I'll talk towards the end of this session. These are visual cards which will help you to revise. Then I will also sell daily short videos or quizzes or master classes. Master classes are the longer length classes, 30 minutes, 35 minutes classes. Live session like this, whenever I go live, there will be a notification in those groups. And also, I'll share a lot of free but very important PDFs. Like there is a PDF of advanced drug reactions. So it's just a 4 page PDF, but you see every year 1 or 2 questions keep on coming. Or mini courses, on a small or important topics. A series of 6, 7 sessions will be there with video lecture, theory, and the MCQs on those topics. So those are called as mini courses. So everything which we create, we send you through this group. This is the daily WhatsApp free group, and you can join it. To join it, you have to go to medicoapps.org/groups. Okay, and when you go, you will have options to join a first year group, second year group, third year group, and based on whichever college of MBBS you are, you can join it so that you can keep getting relevant update. For example, if you have joined a third MBBS group, you will go get more updates of ENT, OPTHA, or PSM, and other subjects also, but more from these three. So it is that's how the groups are created. Let's start with first question for today. And the first question is a 30-year-old woman presented with 3 week history of dry cough and dyspnea on exertion. Okay, so you have a history of dry cough and dyspnea of exertion. It is to be noted that there is no history of fever. Okay, on evaluation, patient was found to have elevated angiotensin converting enzyme. ACE levels are increased, and her X-ray is shown. What is the likely diagnosis? So, what you can see in the X-ray. So, this is the X-ray. What you can see is in the X-ray. Would anyone like to comment? What can you see in this X-ray? Anyone? What can you see? This is a very classical X-ray. So you can clearly see the hilar lymph nodes being enlarged. Now, so you have a patient presenting with dyspnea on exertion and dry cough. Age, 30 to 40-year-old patient. So that is the presenting picture. There is no mention of fever, so we can take it that there was no fever. ACE levels are increased. Okay, and the last is you have got hilar lymph node being enlarged. I think if I write these 3 things, your diagnosis is pretty much clear. So we are going to, this is clear cut a case of sarcoidosis. This is a sarcoidosis case. Okay. Let's rule out all the other. So why I have ruled out pneumonia? Because there is no history of fever. There is no history of fever. Even tuberculosis, there is no history of fever. And in TB, ACE levels are normal. Remember, ACE levels are normal. It can be elevated in miliary TB. In a miliary TB, but this is not a picture of your, miliary TB. Is it clear? And again, histoplasmosis. Again, ACE levels are normal in histoplasm. Both of these, remember, can have Euler lymphadenopathy. Euler lymphadenopathy can be seen in both of these. But remember, ACE levels will not be. In tuberculosis, if it is a miliary tuberculosis, yes, it can increase, but otherwise it will. So your answer here is sarcoidosis. Any doubt, anybody? I'm just reading comments if you have put it. Any doubt, anybody on this question? Okay. But again, sarcoidosis is a super high topic. So let's look at some of the most important, clinical features or important points about your sarcoidosis. Okay. So when I talk about sarcoidosis, let's start with the clinical features. Let's start with the clinical features. So when we talk about clinical features, so what are the initial symptoms? Can anyone tell me? What are the initial symptoms of presentation? So remember, when we talk about clinical features, the initial symptoms are very, very vague. Vague. So it can be like fatigue or lack of energy or weight loss or sometimes pain in joint. So very, very vague and non-specific, non-specific presenting features can be there, like night sweats, fatigue, lack of energy. But what will bring the patient to you is basically a dry hacking cough, okay, which is also accompanied with dyspnea on exertion. Even dyspnea on rest can be there, but dyspnea on exertion will be there. And sometimes the patient may also present with stridor, because these lymph nodes become very, very big and it may cause stridor. So these are the general presenting features. Now, sarcoidosis is a systemic disorder, so you have to know what are the systemic clinical manifestations of sarcoidosis. Okay, so remember, they present with vague non-specific symptoms like fatigue, loss of energy, joint pain, which we generally disregard in our clinical settings. We think that the person is complaining like that only. But what will bring the patient to you and what will catch your attention is cough, which is not being relieved by normal antitussives which you are giving. There is also dyspnea on rest or exertion, and sometimes there will be stridor. So these is the generally presenting feature. Let's look at system wise. What are the various manifestations, and you have to remember it. So let's pick up one system by. Let's talk about central nervous system. So what are the things? So remember, one of the most common features in central nervous system will be your optic neuritis. Optic neuritis. Okay. The second will be lymphocytic meningitis, and even these patients can have central diabetes insipidus. So lymphocytic meningitis and central diabetes insipidus. So these are, and most commonly, optic neuritis will be the central nervous presentation. Also, you have to know the ocular presentations. So what are the ocular manifestations of sarcoidosis? So one we have already listed out, optic neuritis. Then you also will have uveitis and peritonitis. Uveitis and peritonitis. So these are the ocular manifestations. Okay. Then also, if you see what are the respiratory manifestations, so respiratory we have already seen. What are the respiratory manifestations? Anyone? So remember, bilateral, hilar, lymphadenopathy, fibrosis of the lung. And can you tell me which lobe of the lung is specifically involved in sarcoidosis? Which? So we know there is upper lobe, middle lobe, and lower lobe. So which lobe is generally involved? So remember in sarcoidosis, and let me put it in a different color so that you will remember it. It's the upper lobe fibrosis, which is most common. It is the upper lobe fibrosis. Another very characteristic and very important, exam question is you will have egg cell calcification. So basically, all these lymph nodes they will start accumulating, calcium, and that is what you see called as egg cell calcification. Okay. On a side note, very frequently they are going to ask you what are the causes of upper lobe fibrosis. Upper lobe fibrosis. If anyone knows, kindly put it in the live chat. If you know the causes of upper lobe fibrosis, put it in the chat box. So one I have already listed, sarcoidosis. What are the other causes of upper lobe fibrosis? Yes, very good. Tuberculosis. And the third, ankylosing spondylitis. Super important MCQ. Very important. Upper lobe fibrosis. So this is the rated recipe. Now let's look at what are the liver manifestations. So what are the liver manifestations? In liver, you will have granulomatous hepatomegaly. Okay, so granulomatous hepatomegaly you can see. What are the cardiac manifestations of sarcoidosis? So you can have ischemic heart disease. You can have ischemic heart disease. You can also have heart block or tachyarrhythmia. So rhythm disorders can be there. And most importantly, you can have pulmonary hypertension. You can have pulmonary hypertension. In an exam, in a clinical case, how do they talk about pulmonary hypertension? Anyone? How will they say about pulmonary hypertension? So whenever they are mentioning loud P2 or they say decreased in the diffusion capacity of diffusion lung carbon monoxide gas. Both of these are indirect indicator of pulmonary hypertension. Is it clear? So these are the cardiac manifestations. Let's look at how will what are the things which you are going to find in bone marrow. Remember, all these points are MCQ points because sarcoidosis is a super high important point. So lymphopenia can be there. And the last, but probably the most important, even though I'm mentioning it at the last, the most important is skin manifestation. Let's look at the skin manifestation. Super important. So can anyone tell me what are the skin manifestations of sarcoidosis? So the first one is lupus erythematosus. What happens here is you have painless, reddish discoloration of nose and cheeks. Okay, so nose, bridge of nose is involved and the cheeks is involved. Okay, so that is lupus erythematosus. You can also have erythema nodosa. You can have erythema nodosa. So erythema nodosa again on the legs, they will be painful swelling. So you can have lupus erythematosus, you can have erythema nodosa. So these are the clinical features. So once again, in sarcoidosis, generally presenting feature will be vague, non-specific, dry hacking cough, which is not relieved by normal antitussives, along with dyspnea on exhaustion or dyspnea on rest. Sometimes stridor. So these will be the general presenting features, and then you have CNS manifestations, respiratory, ocular, then liver, cardiac, bone marrow, and skin manifestations. All these are, super important. Let's look at some of the investigations which we'll do. What are the investigations we'll do to how will we work up this patient? So when I talk about investigation, so one we have already seen in this question. What was the investigation given in the question? The X-ray. So in X-ray, what we can get is bilateral eyelid lymph node, and even Excel calcification. Okay? Excel calcification. These are X-ray findings. How do you diagnose? So what is the investigation of choice in this case? So we will have endobronchial ultrasound guided biopsy. Okay. So we will biopsy is the investigation of choice, and we can go for a endobronchial biopsy, or we can also go for a transbronchial biopsy, depending upon the location of the granulomas. Okay. Location of the granuloma. So investigation choice will be biopsy, preferably endobronchial or transbronchial. Okay. We can also do a bronchoalveolar lavage, and what we will find in the bronchoalveolar lavage, we will find lymphocytosis. Lymphocytosis. So this is how they are going to talk about it. And remember, in lymphocytosis, there will be increase in the CD4 count as compared to the CD8. Right? So this is it. We can do a PET scan, we can do a cardiac MRI, and one very interesting finding: ACE levels. So ACE levels will be increased. So what are the conditions where ACE levels are increased? Can anyone just tell me what are the conditions in which ACE levels is increased? Anyone? So the mnemonic of ACE levels increases S, G, L, T. S is, we have already called, sarcoidosis, but along with sarcoidosis, silicosis. Okay. So this is S. G is for a lysosomal storage disorder, Gaucher's disease. Gaucher's disease. L is and T, very leprosy. And T, I have told you TB, but it is miliary TB. Remember, disseminated TB. And T also stands for thyroid. So hyperthyroidism. So these are the conditions where your how do we manage a patient? How do we manage a patient of sarcoidosis? How do we manage a patient of sarcoidosis? So we generally will use steroids. So steroids will be used, and generally, we try to taper the dose to very low dose steroids. And sometimes when we cannot give steroids, in those cases we can use methotrexate. Okay, there are certain conditions when the patient is having lots of so side effects of steroid, then we can use methotrexate. We can also use azathioprine. Okay, and another very interesting drug, infliximab. Even this can. Is it clear? So this is how we manage our sarcoidosis patients. So the mainstay of treatment is steroids. Is it clear, everybody? So sarcoidosis, whatever I have taught in past 5-7 minutes, becomes super critical for your examination. Okay. Let's look at the. So this was the question. So now you will be, after going through the sarcoidosis, this question becomes a cakewalk. 30-year-old, 3-week history of dry cough, is neon exertion, ACE level increasing, and what you are finding is hilar lymph node. Okay. So this is a clear-cut case of sarcoidosis. Tell me if anyone has any doubt in this question. If anyone has any doubt in this question, anyone? Okay. So let's look at the next question for this. Most common type of multiple sclerosis is. Again, MS is a super high-end topic. What is the most common type of multiple sclerosis? So the options are remitting, relapsing, secondary progressive multiple sclerosis, progressive relapsing multiple sclerosis, and primary progressive multiple sclerosis. So anyone wants to answer this question? What is the most common type of multiple sclerosis? Is it relapsing remitting type? Is it secondary progressive multiple sclerosis, progressive relapsing, primary progressive multiple? Basically, relapsing remitting is when there is an episode of exaggeration, then there is normal, exaggeration, normal. So it is relapsing remitting, relapsing remitting. This is secondary progressive means initially it had this relapsing remitting course, okay, but now it is progressive. This is called as secondary progressive. progressive. It means initially the symptoms for 1, 2, 3 years are increasing, relapsing, remitting, relapsing, remitting, relapsing, remitting. But now it is just increasing in the symptoms. So this is called a secondary. Primary progressive is even from the start, the symptoms have been increased. Is it clear? And progressive relapsing multiple sclerosis. Here, you know, it is relapsing remitting, but with each relapse, the symptom is increasing. With each relapse, the symptom is increasing. Okay. So here, the difference between this and this is basically in relapsing remitting. Once it goes down, the next relapse is as severe as the last one. Here, it is increasing. So these are the various types. Any guesses for this question? Which will be the most common type of multiple sclerosis? The correct answer is relapsing remitting type. So this is the most common type of your multiple sclerosis. Now, let's look at important points about multiple sclerosis because again, it's a very high topic. So let's start learning about multiple sclerosis. So we know what is the pathogenesis. So basically, it's an autoimmune disorder again, autoimmune, and vitamin D deficiency also has been implicated. Okay, and so what happens in this case? Okay, so basically there is a T cell mediated inflammation against the myelin basic protein. Okay, so T cell based inflammation against the myelin basic protein. So what will this do? This will lead to increase in the blood-brain barrier permeability. Okay. Also, so one is a T cell mediated, but remember there is also a B cell antibody, and this antibody is against your myelin oligodendrocyte glycoprotein. Okay. So both there is a T cell mediated and a B cell mediated. So both antibodies as well as CD, and what will ultimately both of these do? Okay. And remember, it is because of the blood-brain barrier permeability these antibodies enter into the blood, into the brain. So both of these will lead to demyelination. Along with demyelination, which means destruction of the myelin cell, there will also be axonal damage, which means the axons also will be damaged. And both of these, what are they going to do? They are going to reduce the cell property movements, conduction. So we know that in nerve conduction, the conduction is generally from node to node, which is why the nerve conduction is very, very fast. So there will be decrease in the nerve conduction because of the demyelination and axonal damage. Also, this demyelination and axonal damage, what it will do? It will lead to gliosis, and this gliosis will lead to plaque formation. So this is the pathogenesis of multiple sclerosis. Remember, it's an autoimmune demyelinating disorder wherein the etiology may be autoimmune. Even in some cases, vitamin D deficiency has been implicated. So there is both T cell based inflammation and B cell antibody damage. The T cell is again myelin basic protein. So the T cell inflammation is against the myelin basic protein, whereas B cell antibodies are against the myelin oligodendrocyte glycoprotein. Okay, and because of the T cell related damage, there is an increase in the blood-brain barrier, and which will lead to these antibodies. These B cell antibodies will start entering. Okay, and once there is a demyelination, there is an axonal damage, which will lead to the decrease in the brain conduction or the nervous system conduction. And eventually, because there is axonal damage and demyelination, there will be gliosis and plaque formation. This is basically how the pathogenesis of multiple sclerosis will be there. So, what are the clinical features? What are the clinical features? So, remember, the most common, sensory symptoms are optic neuritis. This is very, very important for you. So, optic neuritis is the one of the most common sensory symptoms. So, generally, Vague sensory symptoms may be there. Sensory symptoms may be there. But we talk about specific, okay, then there will be optic neuropathy. So these are the general presenting features. Then you can also have internuclear ophthalmoplegia. So you can have internuclear ophthalmoplegia. Okay. So basically there will be a ipsilateral sixth nerve palsy and ipsilateral medial longitudinal fascicular spasm. So basically, there will be a difference. So if the patient is asked to move his eyes sideways, if the patient is asked to move his eyes sideways, then whichever ipsilateral, whichever side the damage will be there, in that side the patient will not be able to move the eyes sideways. So because of the intranuclear ophthalmoplegia. They can also be facial nerve palsy associated. They can be also be facial nerve palsy. Then as and when wherever the plaques will be formed, that kind of symptoms can be there. They can be ataxia, they can be vertigo, even diplopia, deafness, trigeminal neuralgia, or glossopharyngeal neuralgia. If the patient is having glossopharyngeal neuralgia, when he is eating something, he will feel severe pain as if he is eating something very thoroughly. Okay, you can even have facial myokymia, which means there is a facial movements of muscle, flipping movement of facial muscle. You can also have autonomic nervous system being involved. So you can have extrusor muscles, the urinary bladder hyperreflexia. Okay. So wherever it will be, wherever these nerve plaques will be formed, all those places. And as I have told you, how will they present? So they can have a relapsing, remitting kind of a course, and this is the most common. So the patient will have symptoms, then a disease-free period, then symptom, then disease-free period. So this is called as relapsing remitting multiple sclerosis. Then there is a secondary progressive multiple sclerosis, which means a patient initially is having this relapsing remitting course, okay, and then maybe one or two are like this, and then the symptom never had a symptom-free period. So then it is progressive. So this is called as secondary progressive. Okay. The third may be primary progressive, which means patient from first only never had a relapsing remitting course, but always a progressive. So this is called as primary progressive, which is relatively rare. And the third may be, when he is having relapsing, remissing, relapsing, but with each relapse, the symptoms are increasing. So remember, this is the relapsing remitting type is the most common type for multiple sclerosis. These were the clinical features of multiple sclerosis. So here, the most common type of multiple sclerosis, remember, it is the relapsing remitting. So lots of question again has been asked on multiple sclerosis. Multiple sclerosis, they can put clinical question also in front of you. Okay. So this was it. Let's look at this question. Which of the following has no role in management of Guillain-Barré syndrome? Put in your answer. Which of the following has no role in Guillain-Barré syndrome? Management of Guillain-Barré syndrome. Which of the following has no role in management of Guillain-Barré syndrome? So steroids, plasmapheresis. So we know it's an autoimmune disorder. It's an autoimmune type 4 hypersensitivity reaction. So which of the following does not have any role? So let's look at this. Plasmapheresis and immunoglobulin, we know these are the treatment of drugs. The only thing is people get, because it's an autoimmune disorder, steroids, they may think that it will have a role, but steroids have been shown to have no role in management of bullying, not particularly be very effective. And yes, because there will be ultimately diaphragmatic paralysis, the patient will require a ventilatory support. So the best answer here is steroids. Let's quickly learn few important points about Guillain-Barré syndrome. So we know that it is an autoimmune disorder. It is acute, it is progressive, okay, and basically it's a type 4 hypersensitivity reaction. Okay? And what happens in this is there is a demyelination of the peripheral nervous system. Okay? So if it is an autoimmune hypersensitivity reaction, then there has to be hypersensitivity to certain pathogens. So what are the etiological agents? What are the etiological agents? So one very important is your COVID. So a lot of this COVID patient actually had Guillain-Barré syndrome. Okay. Then you can have Epstein-Barr virus, EB virus. You can Zika virus or hepatitis E virus, even SLE patients. So all these can present after, can have autoimmunity or type 4 hypersensitivity reaction presenting in form of Guillain-Barré. And remember here also there is both, if you go and see the pathogenesis, so there will be both destruction of myelin sheath along with axonal damage. Along with axonal. Okay. So this is. So what are the clinical features? So how does this Guillain-Barré? So how does this Guillain-Barré syndrome present? Okay. So remember, it presents as an acute disorder and a progressive disorder. So the person will be fine, and suddenly one day he will start having symptoms. Whatever symptom I'm going to talk about, one by one, over next 4 weeks, these symptoms will start appearing. So they can patient slept on well nicely. So there will be some episode of this infection, and then 1 2 to 3 weeks or 4 weeks after that initial infection, these symptoms start appearing. So what is the first symptom? So there is basically a flaccid paralysis of the lower limb. So it's a ascending paralysis. It will start from lower limb and then flaccid paralysis means the tone of the legs. So the patient, when he is waking up in the night, he was very, very fine. In the morning, when he woke up, both his legs are not working. So, he gets worried. No, obviously, both the legs are not working, and he's a relatively young person, does not know, uh, doesn't have a clue why both his legs have no tone or decreased tone. So this flaccid paralysis of the lower limb, then his will be followed by truncal paralysis. What I mean by truncal paralysis, now initially in the morning, let's say only his legs were not having power, but he was able to sit. Suddenly, because of the truncal muscles paralysis, he will not even be able to sleep. So he will again be lying in the bed. Okay, and this will be followed by your arms weakness leading to quadriplegia. So you can see there is a ascending paralysis. And remember, in Guillain-Barré syndrome, because this will be very important when you differentiate it with polio. In polio, first of all, remember it's a descending paralysis. Okay, and the second is it's an asymmetric paralysis. Okay, but in Guillain-Barré syndrome, remember it's a symmetric ascending paralysis. Are you able to remember? So once this is there, then there can be a diaphragmatic paralysis. Diaphragmatic paralysis. So he will start having difficulty in breathing. Then neck muscles paralysis. Okay. So you can see how and the symptoms may progress over 2 days to 28 days. Okay, but remember it's an acute disorder. So it's a progressive acute disorder, and this will again lead to the paralysis of your facial nerve. Okay, they can even be bulbar palsy. There can be sensory parathesias, but they're not very marked. So sensory parathesias are not very marked. Very important here, and let me put it in other colors so that you remember it. Generally, bladder and bowel are paired in your Boolean parasyndrome. And this is very, very important when you are going to compare it with your transverse myelitis. Transverse myelitis. Because in transverse myelitis, every feature of your Guillain-Barré syndrome and transverse myelitis will be similar, except two. Their bladder bowel movement will be involved, and their sensory, radiculopathy or pain will be very, very much. Okay. So remember, Guillain-Barré syndrome, this bladder and bowel movement becomes very, very important because they are not. And how do we manage these patients? So we know what is the management. So the most management of choice is your IV immunoglobulin, so that all these circulating antibodies are removed. If that is not effective or not able, then plasma pheresis can be done. And the efficacy of both of these are equal, almost equal. But if both is there, first we'll go for IV immunoglobulin. Okay. Then obviously, because of the diaphragmatic paralysis, ventilatory support is critical, and even tracheostomy is maybe required because patient may be on ventilator support for quite some time, and after recovery, rehabilitation becomes very, very. So this is management of Guillain Barré. Is everybody clear? Okay. So the correct answer here is which of the following has no role? The correct answer is steroid, because both of these are very, very important. Efficacy is equal, but if you have to choose one, always choose IV immunoglobulin because it is less invasive. Ventilatory support has important role. Steroid has not been proven to have any role in management of Guillain-Barré. Let's look at this question, and this will be the last question for today's session. Which of the following is the best represents a lab abnormalities in intravascular hemolysis? Again, anemia. So again, super important. So let's look at what is going to happen whenever there is an intravascular hemolysis. Okay. So we know that whenever hemolysis is going to happen, so the first thing is there will be release of reticulocytes from the bone marrow, and this will be seen as reticulocytosis. Also, it will be represented as high increased in the mean corpuscular value because all these reticulocytes are relatively larger. So intravascular hemolysis, increased MCV will be one of the features. Also, because the hemolysis is there, the hemoglobin is broken down. This hemoglobin will be converted into bilirubin. So remember, there will be increase in unconjugated bilirubin. Unconjugated bilirubin will be increased, and this unconjugated bilirubin will be further converted to urobilinogen, and so urinary urobilinogen also will be increased. Okay. Now, this hemoglobin will initially be taken up by haptoglobin. So haptoglobin level will tend to fall. All these are features of still if hemoglobin is there, so this will lead to hemoglobinemia, that is increased in the hemoglobin, free hemoglobin in the blood, which will lead to the hemoglobinuria, which means hemoglobin will start coming in urine, and hemocinuria. So all these are classic manifestations of your hemolysis. So let's look at the question. So which of the following has intravascular hemolysis? So we have seen high MCV is seen. Why high MCV is seen? Because of the reticulocytosis. So we'll eliminate these two options. Low haptoglobin, yes, low haptoglobin because this excess hemoglobin will be combining with haptoglobin, free haptoglobin. So haptoglobin level will come. Okay. Low LDH or high LDH because all these will be going and getting processed in your liver. So the liver LDH value will be increased. So it will be high LDH and high urinary urobilinogen. Because I told you all this bilirubin will be converted to urobilinogen, which will come out in the urine. So the correct answer here is okay. Is everybody clear in this question? So this brings us to the end of this session, and as I told you that we talk about something called as concept card. And why the idea of concept card came is that Whenever I talk to my students, they work very hard and they are always worried about, sir, I have learned it, but I keep forgetting it. When I say that, have you revised? They say, sir, revision is the biggest challenge. And why revision actually is a very, very big challenge for all my students, because there is lots of information. Trust me, there's so much to remember that, it becomes the kind of information which you have to remember is so huge. And again, revision is not something very, very exciting. If you see a new lecture, you're excited. If you solve some MCQs, you're excited. But who wants to keep revising things and feel frustrated that, oh, I'm not remembering this, oh, I'm not remembering that. And obviously, even if you revise and go through the pain, you still keep forgetting. So what we have done, we have come up with something called as Medicoapps concept. And what is this concept card? So we have taken all the high points which are generally asked in the examination, converted into image or flowchart, and then we have converted into a active learning, which means suppose if there is a flowchart, we will not give you the entire flowchart. Or if suppose we want you to remember a drug of choice, so we will not give you a drug of choice straight away. We'll put a question mark there so that you can think, and then when you swipe the card, you will see the correct answer. So it is more of an active learning, which helps students, which makes actually revision very, very interesting. So if you want to have a look at this concept card, you can follow us on Instagram. On Instagram, we are posting lots of our newly created concept card. Also, you can go to the Google Play Store and search for Medico apps concept. Okay, and once you search for this concept card, you can download the app, and for 14 days you can use it for free. And if you like it, you can go for the paid version. Again, before I end, I would like to remind you of our daily update WhatsApp group, which I have created, and I personally send these updates to you via WhatsApp. It's a no only admin post group. What do I mean by that? No side talks, no good morning, no good evening messages. Only I will post critical updates, important updates, high-end updates in the group. And this brings us to the end of today's session. So this was session 9, 3rd May. And tomorrow again there is a session, and that will be the 10th session in the series. So this series I have just started, and I have committed that every week I'll try to take 3 or 4 sessions, all of them on high topics, so that you keep learning, keep understanding, and keep focusing on the high topics from an exam point of view. So with this, we come to the end of our session. Any question anyone has? Any question anyone has? So if nobody has a question, let's meet again tomorrow.